Thank you. So after a long day, we come to again discussion of PARP inhibitor, linpazine, HRR mutated metastatic CRPC. Can I have the slides on the screen? So I think all of us will agree that we have understood the importance of PARP inhibitors in most of the cancers, including ovarian cancer and prostate cancer. And the time which we are seeing is the era of the targeted therapies and immunotherapies. So we see a lot of new cases of prostate cancer at TMH Varanasi. We see every day 5 to 7 new cases of metastatic prostate cancer. This is I'm talking about metastatic prostate cancers because this number I am very well aware of because we try to enroll every patient of metastatic prostate cancer in some or the other trial. We have one of the trial ongoing of HRR mutated prostate cancer. Irrespective of HRR mutated patients, they are going to be enrolled in EvoPAR study, that is a drug called saruparib along with ARPIs. Another trial is investigator-initiated trial of docetaxel plus abiraterone, where we are giving 2 doses of abiraterone. We have other 3 more trials, utilization of endoxin dexa for metastatic CRPC. Apart from that, utilization of altered doses of docetaxel in patients with age more than 65 years. So I think that is the way we try to enroll most of the patients in some or the other trials so that our patients can get the best possible treatment. So most of our patients are again elderly, more than 60 years, and we utilize the benefit of geriatric clinic for most of our patients who are getting treatment. So that is another area which I wanted to highlight, the importance of geriatric clinic in the practice and the treatment of older patients with cancer. At the same time, if you see, this is the age group, but India is seeing a shift of younger prostate cancer. So young prostate cancer is another very important area of research, and patients with less than 60 years of prostate cancers are standard young prostate cancer. Another subgroup, very young prostate cancer, less than 50 years. This is also a significant number. So I think these all patients are mostly driven by HRR mutation. So that is becomes the important. So we are concentrating upon metastatic CRPC today. And we know that, yes, the outcomes are really bad. And what is importance that metastatic prostate cancer is a wide heterogeneous disease. If we see that it comprises of multiple types of prostate cancers, that includes HRR mutated patients who are aggressive variant prostate cancer. For AVPC, that is aggressive variant prostate cancer, we are trying to do testing baseline itself, that is P10IHC, P53 and RB gene. These help us to identify aggressive variant prostate cancer, and we understand which patients you need to be aggressive and where you can go slow. So go slow, go low. These are all the terms which we have learned from our geriatric clinic. Go slow is an important strategy for older patients, and we try to adapt accordingly. Mutations in DNA repair pathways are very important, and these are always tested. As we all know, MSI high, though a rare mutation, they are rare finding, but we have found 1 or 2 MSI high patients in prostate cancer, but those are not very common. But HRR repair mechanism deficiency is an important pathway. Up to 8 to 10% of the patients in our data sets have HRR mutations. So this is the database of BRCA2, though we know that BRCA2, germline, and somatic only. These are the most important findings for HRR in prostate cancer. But yes, there are multiple other mutations, ATM and CHEK2. Now there is some data that ATM might not be so beneficial for giving a PARP inhibitor. So coming further ahead, so what is the rationale for PARP inhibitor? I think we have understood it from the time we started to utilize PARP inhibitor for ovarian cancer. These gene alterations actually confer sensitivity to a PARP inhibitor so that the damage which has been done by a treatment, that becomes a permanent, and the cancer cell can die. The PROfound trial, which we see that it has been a very important trial which paved the way of inclusion of PARP inhibitors in treatment of metastatic CRPC. This is the patients who have PS0 to 2 were allowed. There were 2 cohorts, BRCA 1 and 2, and other or ATM mutation. In the cohort B, other HRR mutations were included. Both had 2:1 olaparib versus physician choice treatment, and there was an optional treatment to go to olaparib arm at progression. Primary endpoint was relapse progression-free survival. And if we see, this is the gene panel which was utilized, cohort A, BRCA1, BRCA2, and ATM. Now, ATM is also not regarded as very significant, so it is coming into now cohort B for us only. But in this study, cohort B comprised of other mutations other than BRCA1, BRCA2, and ATM. So baseline characteristics were well matched in the two arms, and you can see around 50% patients were having performance tests of 0, and most have received some form of new hormonal agent, and previous taxane use was seen in close to 60 to 65% of the patients. If going further ahead, if you see, CDK12 mutation was also one of the most prevalent gene, and apart from BRCA2 and ATM, this was regarded as an important mutation in patients with HRR mutations. So CDK12 has there is a recent analysis, meta-analysis, where CDK12 has been also identified to be an important mutation for HRR, for which PARP inhibitors are useful. So apart from BRCA2, BRCA1, third most important mutation for treating with PARP inhibitor is CDK12 now. Other mutation which is very important is RAD51D, which we tend to find in some of our patients. So those are the important. And also PALB2 is an important mutation which we tend to get in our reports. So we have done HRR testing for more than 500 patients till now, and these are the findings. Close to 7% patients having HRR mutations which are of significant value. That means either BRCA2, BRCA1, CDK12, or PALB2. These four are the most important HRR mutations for us. And in this trial, PROFOUND met its primary endpoint by improving significantly relapse progression-free survival, radiological progression-free survival. You can see the 6 months PFS rate was improved from 22 to 60%. So more than doubling of the response, curves separating very, very early, as soon as 1 to 2 months. You can see when the first scan was done, then only there was a significant separation. And you can see the median PFS was improved from 3.5 to 7.4 months. And this you can see, this progression, this benefit is being seen in nearly all the subgroups, including PS2 patients with any ethnicity and baseline PSA raised or less than normal. And cohort A had very significant improvement in the objective response rate, which was just meager of 2% to improve to close to 33%. That means every 1/3 patient is having objective response rate with the utilization of olaparib. Similarly, at the interim analysis, there was a 10 to favorable overall response as well, despite 80% crossover. So giving PARP inhibitor early is also the key to the treatment, which we have learned from our lesson from the ovarian cancer. It is very clear. The patients who are getting PARP inhibitors earlier are having significant survival benefit. And you can see 15 versus 19 months. And similarly, the data is coming very strongly. This is the more important thing, that objective response rates are also significantly improved. And the final overall survival data is statistically significant. Final overall survival benefit in BRCA1, BRCA2, or ATM mutation, that is cohort A versus physician choice. That was around 14 versus close to 20 months. So data is very clear that the patients with HRR mutations are having significant benefit. So we have tried to incorporate now olaparib as early as possible in the treatment of patients, preferably in the second-line treatment in metastatic CRPC, as soon as they get diagnosed with some important HRR mutation of significant value. Also, the health-related quality of life functions are improved with this treatment. And we see that in this trial also, the patients had good improvement in the quality of life, and it was not at the cost of worsened toxicities. So that is the most important point. And I think there is more to this, that better PARP inhibitors are also under development. Drugs like saruparib, which is known to have less PARP2 inhibitory activity and more PARP1 inhibition, is expected to be having less toxicity, at the same time having more good responses. And in this study, around grade 3, grade 4 adverse effects were seen in close to 50% of the patients with olaparib. And that is what we have understood and what we know already. So yes, we know to be cautious. Hematological toxicity is most important. MDS, it was found in less than 1.5% of the patient. Pneumonitis, this was reported in also less than 1% of the patient. Yes, pneumonitis was reported in 4 patients treated with olaparib. 2 had resolved and 2 in the control arm did not resolve. So yes, pneumonitis can occur. Be cautious, utilize, but it cannot be life-threatening if you have utilized it correctly and managed it accordingly. So if we see the majority of the sample received in the biopsy for HRR mutation in this study from the primary tumor, and if you see the success rate, test success rate in this study, you was a good number of patients had successful, but yes, around a significant number of patients could not be enrolled in the study because were not able to be randomized because tissue success rate was not there. So yes, it is important that we need to collect fresh samples, and also it should not be very old sample. More than 3 years old sample have less chances of getting positivity with HRR testing, and this is the result. And HRR alteration was found in around 28% of the patients if all the mutations are included in this trial. So test failure is a possibility, and that can occur due to pathology failure, poor DNA extraction, and failure after DNA extraction as well. So blood testing is an important option, and it is now being practiced, which is very commonly performed apart from germline testing. So cfDNA based testing is becoming the standard of care very rapidly, and that is a recommended option. So it is a good option that we can simultaneously process the tissue and the blood. And if the tissue fails, we can directly start with the blood-based testing, so that plasma CT and DNA-based testing is becoming more important. And this is the preferred algorithm, as I've discussed. Tissue, if it is unsuccessful, directly process the plasma CT DNA testing or blood lines as well. This is very clear. The panel clearly recommends to do testing for tissue, and at the same time, if we are performing germline testing, it should be in patients with family history, especially with pancreatic, breast, and ovarian cancers, and that is becoming more and more important. So guidelines are now very clear that patients, and this study clearly showed the patient with HRR mutations had significant improvement in the outcomes with doubling of the radiological progression-free survival and overall response rates, and benefit was seen in even when patients with prior taxane use. So it is independent of prior taxane use, and tolerance is well established, and tissue failure of testing is possible, but can be circumvented possibly by utilization of blood-based ctDNA based testing. And this is the first positive biomarker selected phase 3 study for PARP inhibitor in prostate cancer. Thank you for your patient listening.